Welcome to the Healthcare Intelligence Podcast. Today we have Dr. Hockstein joining us. Dr. Hockstein is an ENT specialist specializing in head and neck surgery, and he currently serves as chair of the Delaware Health Care Commission.
Thank you for having me.
Of course, and not every day do we have a ENT specialist and someone who is well versed in state policy. So we're lucky today. And just to get us started, how did you go from ENT to state health policy?
So there was never a master plan. I never set out to do this. I feel very fortunate to have done a variety of different things at different times. But what happened, which I think is a story that we'll hear many times, is that COVID really changed my life. I'm a practicing physician. My wife's a practicing physician. And in the early days, there were reports of ENT specialists. My wife's an ophthalmologist, and ophthalmologists who, by the nature of the work we do, our faces are close to our patients' faces, we're dying. And so we wanted to be both good citizens, care for our patients, but also, intensify the care that was being provided in the emergency rooms. And so we felt we needed to keep our practices open, and we needed PPE. And so testing required identifying vendors. I started working with our county executive at the time. And the COVID testing process requires many steps. It's identifying people to be tested. It's identifying the lab. It's having the personnel to do that work. And so together we built a county testing site, and we also built a testing program for Delaware State University, which is our historically Black college in Delaware. We built a testing program and eventually a molecular diagnostics lab through the county. We scaled and we built county testing sites and eventually state testing sites with a vendor, and really made Delaware, which is a small state, a very easy place for testing. And the next step was vaccination. And we are an ENT and allergy practice. We give 1,000, or at the time we were giving 1,000 allergy shots a week. We knew that we could help in this process. So I contacted the Division of Public Health in Delaware. Our county executive at the time, Matt Meyer, runs for governor and wins. And so while he was working to develop a health policy, given all the work we'd done together during COVID, he asked me to come along for the ride. And after he was elected, asked if I was interested in chairing the Health Care Commission. And so I didn't see a way, as a person who cares about my state and my country, to turn that down, because I really think states are going to lead. And so that's what I did.
Awesome. I mean, I think the powerful part of the states is the closest to the people, right? Like the part of access, the part of community, a lot of that is very relevant to healthcare. And I know that's a part you care a lot about. So I would love to hear more about how you're bringing community into the public health mission.
Sure. So I didn't know exactly what my vision for healthcare for Delaware was going to be. I knew there were a lot of problems we needed to solve. There's a lot of work, frankly, countering some of the misinformation and some policy changes coming out of DC. But ultimately, I wanted to distill it down to what matters most. And there's a lot of news about childhood vaccination, about respiratory vaccination, and that's important. But I think if you ask most people, they're concerned about healthcare access and affordability. And in most of the country, primary care is a problem. In many parts of the country, but especially rural parts of the country and rural parts of Delaware, certain subspecialty areas are very challenging. And so we know that if we provide great access to primary care, if we provide great access to healthcare and make it affordable so people are receiving lower acuity care more frequently, that we're going to drive down the cost of care, raise the quality of care, and raise people's quality of life. People should not spend more time thinking about their health insurance than their health. People shouldn't spend more time trying to schedule a doctor's appointment than actually seeing the doctor. And so that became a central part of what we're doing. And along with chairing the Healthcare Commission, I also chair our state's primary care reform collaborative. And so working on what are the strategies to ensure we have a robust primary care system, Much of primary care centers on the way we pay for care and how patients are attributed. And so figuring out what are the rules that the payers and the providers can agree upon. So we know if you have value-based care, but you don't even know who the patients are on your panel, you can't provide care in a way that has a level playing field, where the providers, who sometimes have a softer voice than the payers, can be comfortable with.
I mean, value care itself is a payment model, but a lot of people have, treat that as like the strategy and the way care is delivered. So we'd love to just have you talk a little bit more about that and how VBC works in an ideal world and also realistically.
Yeah. So look, I think we would all agree that VBC to date hasn't changed the way we deliver care, right? So I see it as two different things. We have value-based care as a payment model up here to incentivize the delivery of appropriate care. And then we have the doctor-patient or the provider-patient interaction, and we need to transform the way we deliver care. So we need to be delivering high-frequency, low-acuity care rather than low-frequency, high-acuity care. We want to see patients, whether that's in person, whether it's virtually, or whether it's digitally. So we know what their blood sugar is. We know what their blood pressure is. We can have a care pathway that keeps them out of the emergency room for bumps, scrapes, and non-urgent issues, right? We need to identify who are the patients that are the most expensive to the healthcare system, and how do we lean in to provide them the care that they want. We think about people going to the emergency room to get primary care or to solve problems as being a challenge for our system. The reality is it's a challenge for our patients. If you have an appointment and it's a virtual appointment and it is running on time, you don't leave your home, you've 15 minutes, you get the care that you need, and your life goes on. That same interaction in an emergency room is many-fold more expensive and takes the patient out of a place of comfort, puts them to a place of significant discomfort, and it's inconvenient, inefficient, and unpleasant, right? So we need to identify the really challenging, sickest patients with the most complicated care management, and we need to lean in and figure out how we help them. Just that alone would be a huge cost savings, and it's a huge opportunity to provide dignity to patients. And so that's value-based care. And there's value-based care just managing blood sugar and blood pressure better. And there's value-based care in ensuring that patients address their disease processes early rather than late. And so we need to transform the care that we deliver, but to do so, we need to have the payment models that incentivize that work.
What I'm hearing also is a new form of quality reporting, right? Like, how do you measure the actual longevity and wellness of the patient, not just how much diagnosis has been done or what procedures have been put in place?
So a lot of what AI has been doing in healthcare is optimizing charts, right? Identifying and attributing diagnoses to patient to change their level of risk, to change the way we're paid, right? That's great for the providers of care. And that's done with a bot, essentially, right? Extracting data. And there's going to be another bot on the payer side that's looking at what are the real diagnoses and has that been acted upon during this visit, or is it just an added in a padded diagnosis to improve payment? And so we're going to have bots fighting with bots. There's no value in that, right? That's just a game that someone will win and someone will lose. But in reality, I think we all probably lose until we actually use technology to provide, portals of care, smoothing out administrative burdens to get us to a healthier community. And so what are the metrics that I think we should be looking at. I think the metrics are: how long does it take to get an appointment? How long does it take if you have a true emergency and you're in the emergency room? How long does it take for you to be seen? How many patients are boarding in the emergency department? How many patients who are ready for discharge from an acute care hospital that don't have a long-term care or acute rehab or skilled nursing facility into which they can be transferred, right? Those are simple metrics that we can all measure that are going to look unfavorable for us as a society. I think those are metrics that are really important. I also think we need to redefine what's important to us as a society, right? What is quality of life? And how do we want to interact as individuals living in communities? And I think that's going to be more of a reckoning over what kind of world we want to live in is. And I think our public health of the middle of the 21st century needs to focus on that. And, we can think of the arc of public health over time. In Victorian London, we wanted to separate our drinking water from our sewage and prevent people from getting cholera, right? Prevent, mass TB outbreaks. In the 60s, we did something totally different. We took cigarettes out of airplanes. We took cigarettes out of restaurants and bars here in Delaware during my lifetime. And that has saved countless lives. And we made it so, I see patients who have head and neck cancers and they're smokers. I never see someone who says, I really want to smoke. I really wish that I could smoke more. I enjoy it. It's a vice, and everyone wants to stop. But we've done that by changing the way people think about smoking. We haven't changed our relationship with technology in that way yet. But when an external actor, like for example in Australia, or there's a town in Ireland, takes away social media from children get happier, and they actually like that there's an external body enforcing it. And I think that that's critically important, that we start thinking about our public health for what it is in a digital and AI enabled world, where we become the product, right? And so I think that we're going to see a lot more about this over the next handful of years, because the way we interact with people, the micro interactions of saying hello, walking down the street and seeing someone who doesn't have AirPods or headphones on and just smiling and nodding at them, that is what builds community and neighborhoods and well-being. And I think that's the public health challenge that we have to grapple with, while doing all the foundational things that are so important, with clean water, clean air, vaccination, microplastics. We can talk about all of those things, but ultimately what's important is that we feel value and purpose and belonging in community.
That's the technology. It's very rarely seen in any medical charts, right? We report on social determinants and different factors, but there's that social media and 21st century problem we have that affects a lot of it. And I think one thing that makes that possible is just having that infrastructure. I would love to hear more about what you are doing right now, because I know data is there's a lot of discussion around interoperability. But still today, it's pretty hard to share healthcare data. So we'll love to see what you're doing there.
That's a great segue. One of the frustrations for patients is you go to the doctor and the doctor asks you 20 questions. And then they refer you to a specialist. And they ask you the same 20 questions. And then you go to the hospital because something went wrong, and they ask you the same 20 questions. And it's frustrating. And patients at the center of this say, well, didn't you see that from my chart? And the answer is no. The answer is we don't talk to each other. our systems don't talk to each other. We have an almost infinite number of electronic medical record systems and a large number of payers. And when I started in practice, I had a dictaphone, but I had a digital scheduling system, right? That kept, insurance data. So when we were frankly mandated to get medical record systems, electronic medical record systems, or be paid less for the work that we do, they were built in a separate silo. And so today, that data is moved through FHIR, F-H-I-R, and the payment data is moved through APIs and something called X12. And the bridge between X12 and FHIR is a fax machine. And we need to have better connectivity. And that bridge, by the way, it would be like having a car drive on the highway and a train run on railroad tracks and try to put the train on the highway or the car on the railroad tracks. It just doesn't work. And CMS is mandated by January 1st that prior authorization needs to be digital. But we can't get the clinical data moving to the patient, to the payment data, right, without a bridge. And so a lot of payers are working very hard to stand up systems to do that work. But if you're a provider and you have 8 or so insurance payers that you work with on a regular basis, and then a patient is visiting from out of town and a 9th payer comes in, or you have a patient who's on Blue Cross of Delaware, right, which is a Highmark product, but someone from Georgia comes in and they've got Blue South. Those 2 Blue products use different verification and prior authorization portals. And so if you're a provider, you have to connect to each of these by January 1st. And then a patient visits and you realize, oh, there's another one that you didn't even know about. And so unless we have an N times 1 hub where every provider connects to one place, every payer connects to one place, we're not going to have this connectivity. We're going to have APIs tangled with each other, replacing faxes that are tangled with each other, which is really problematic. And so we're investing $50 million through the Rural Health Transformation Program into what's called the Smart Health Network, which is taking that N times N problem and turning it into N times 1. We have that as a utility already in financial transactions, right? When you go to a store, you've got a vendor, you've got your bank, and you're the customer. And a credit card moves that data around. It's not that we're using, a Sears card or a Boscov's credit card anymore, or a Shell gas card for those one-to-one transactions. We have 4. We have Visa, MasterCard, American Express, and Discover. Those are the 4 utilities that move that data around. Well, in healthcare, we have an infinite number of transactions, and it's like we're performing those transactions with a Sears card or a Macy's card or a Boscov's card or a Shell card. Well, we can create that same hub, and so we're doing that in Delaware. The contract is signed, and we're really excited about that. And that will start as insurance verification and prior authorization, but it can become real-time claims adjudication. It can become public health reporting. Once you have the rails, you have the data conduits, you can use it for countless administrative transactions. And the way the data moves in this hub, it moves like sealed envelopes, right? And so if you can imagine, I take sealed data, it moves through the hub to the appropriate target, but we're not looking at the data along the way, so we can maintain the appropriate privacy. So we're very excited about that. And we actually have a technical connectathon in Delaware on July 13th in advance of CMS's Da Vinci Connectathon.
That's awesome. And I think the point is also more than just having that whole universal data awareness, but also cutting down the administration costs on both ends, the payer end, the provider end, and also the patient frustration, right? So if everything is more instant instead of 30 days, healthcare can move a lot faster.
That's right. And thank you for bringing up the patient, because that's really, the patient needs to be the key to everything we do. So when a patient comes to me and needs prior authorization, I may order an MRI scan and the patient doesn't know they need a prior auth. But my staff schedules the MRI, arranges for the prior auth. If there has to be what's called a peer-to-peer, where I have to talk to another doctor to get that prior auth, the patient has no idea. And they're just wondering, why hasn't my test been scheduled? Or what's the delay? And maybe a week later, they get a letter in the mail that says it's been approved or it's been denied, but they're totally cut out. And so having a portal where almost like if you order a pizza, right, you'll know they received my order, they're making my order, they're waiting for someone to deliver my order, right? We could have a pizza tracker for prior authorization. So you'll have a provider-facing portal. This is the information that's needed. You'll have the payer-facing portal where you're communicating to the provider what data is missing or what you need, and the patient will have visibility of what's going on. And so it improves patient experience. It lowers costs because this is being built as a public benefit corporation. So rather than trying to extract the highest rents possible, the goal is to create the lowest sustainable cost. And so the model under which this is built is similar to a port authority. If you're in New York and you want to get to New Jersey, you go over the George Washington Bridge. Well, New York doesn't own it and New Jersey doesn't own it. It's owned by a separate entity called the Port Authority. And the Port Authority was created to be a public benefit. If that was sold off to a commercial venture, private equity, on Friday night, when everyone wants to get home to New Jersey from New York, you'd have surge pricing, right? And it would be more expensive to leave, right? The price would just go up, 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 up. And we're trying to do the opposite and have a sustainable utility that functions as a public benefit.
Yeah, because we got a lot of, there was Wistar funding seems to be in trouble now. We'll see what's next. But I think a lot of the initiatives at the national level may run into foreseeable or unforeseeable challenges. That's why having a state policy that makes sure things is going through well, good things are happening up there is important.
I think that's true, but ideally states work together. And so we're really excited that we're talking to a lot of other states to encourage them to join us. We're doing this first, but we're happy to share all of our documentation, all the tech, because patients don't care about their state lines. If you live on the border of Delaware and Maryland, you're going to get care in both places, right? And so, and our payers span multiple states. And so ideally, Delaware, we happen to be first. But there are several other states that are actively engaged and more that are interested in learning. And we hope that this will not turn into our HIE issue, where we have 75 plus HIEs across 50 states. I think Delaware has one, Maryland has one, but some states have several HIEs, which makes no sense because our HIEs don't talk to each other. Right. So we don't want to duplicate the HIE error and have every state build something different. We want to leverage the Rural Health Transformation Program so that we can share what we're doing and build something that is state-led but has national benefit.
Any final takeaway for healthcare leaders? You see it from the physician angle, technology angle, and policy angle. Would love to see if there's anything we'd like to share with someone as a takeaway.
Yeah, I think that we're at this inflection point in history. I think that what AI is doing is, even bigger than what happened with the internet. Because, with the internet, we had a new way to access information. But AI is really changing the way we process information. And it's, I think, obviously going to continue to change our world. I think we need to look at what lies underneath that, and that's human beings. And we need to ensure that human beings and the consequences of our actions are at the foundation of all of the decisions we make, to ensure that, frankly, as a neighborhood, as a state, as a nation, and as a planet, we have the abundance that is at our fingertips, but we don't lose the relationships that give us purpose and satisfaction and health. I think we're poised to do this in a way that we weren't because our technology is advancing. And I think that we're starting to have more of the conversations about what's important to the human condition.
Wonderfully said. Well, Dr. Hockstein, thank you for joining us today.
Thank you. It's a pleasure to be here.